Thank you very much, Jimena, for your kind invitation to this hot topic session. And I'm going to talk about elastography in the current role of elastography in dermatology. These are the three topics I'm going to cover. The first topic will be why now elastography in dermatology, why not before, why now, why in the future. Elastography of normal skin, how we see the elastic or the hardness of the skin and other structures like the nail, as you've seen with Dr. Bosman. Nails are also part of the body, and they may give you some problems that have to be solved for our patients. And I will give you some hints about the current role of elastography in common dermatological diseases, in the tumoral field, in inflammatory diseases, and also in aesthetics. This is what our specialty covers. Then, why elastography in dermatology? Well, as you've seen with Dr. Bosman, most of the time we have very good diagnosis with B-mode and Doppler. But in some occasions, to detect subtle changes in treatments and subtle changes in the prognosis and subtle changes in, let's say, the prognosis factor of some of the diseases we are dealing with, I think that B-mode and vascular Doppler is not enough. Then elastography is going to give us some hints about what's really happening with the physical properties of the tissue. Then that would have a correlation with what's happening with the skin, helping us, I think, to detect earlier diseases. Why we can do this technique on the skin? These are the requirements to perform elastography. The organ has to be close and closer than our skin. There's no organ closer than the skin. We do elastography on the liver, on the thyroid. Why not in the skin? That is very accessible. In fact, we dermatologists take into account, when we explore our patients, we take into account, we touch our patients, we see if it's hard, if it moves, if it doesn't move, then we do elastography with our hands. Why not to have another more advanced tool to increase our clinical ability to see if it is hard or it is not hard? Because this, for us, dermatology gives us information about what's happening with the skin of this patient. The lesions are visible and easily, as you've seen, to locate in ultrasound, and the surface sliding is minimal. In most locations, you can perform elastography. But we have some limits. The limits is superficiality. Then strength is available in superficial, but not shear wave nowadays. We are talking about nowadays. We have to take into account when we are performing shear wave in the superficial areas that now shear waves below the upper 1 centimeter is not very reliable. From the point of view of scientific, we don't have much references about this topic, but we will see that we are starting to have more evidence on the market. This technology is not reaching the final user, that is the dermatologist. Then there's a vicious cycle. We don't have the evidence because we don't have the technology, and the technology doesn't have the evidence, and this is a vicious cycle. Then it's good such as kind of sessions like the one we are having now to change our knowledge, the technology and the clinicians, to share a common view of what's important for both of us. But we are going to turn those limits into milestones. And the first milestone is to know how we see the skin when we perform elastography. This is the common elastogram when we see the skin. In general, when we see collagen structures, collagen tends to be hard in comparison to fat. The dermis, as Dr. Gormans has said, is mainly collagen structure. Then it is usually hard. Fat is usually softer than collagen. Then we see it in this bluish or greenish color. You see here these tracts that is the collagen tracts you've seen with Dr. Borsman in panniculitis. Then we have a correlation of the hardness of the structures you've been seen before in big mode. Well, you have to take that into account when you come to diseases. What happens with shear wave? Is this shear wave correct? We do not know, because it should do with the ability of our machines to perform shear wave in the upper centimeter is limited. Then that's something we have to work. Well, we have to work with engineers to work it out, to have these velocities in the upper surface of the skin. And the nail. In the nail, we see here the nail plate that is usually hard structure. This is a nail bed. As Dr. Borsman has said, there's lots of vascularity here. Vessels are more prominent in this area here when we look at the Doppler, and it's correlated with this soft area here, and this is the bony surface that is also hard. Then we have what is normal in the nail also. Then changes can be also spotted. Now we are going to with the pathology. We know that in general tumors tend to be more rigid, malignant tumors tend to be more rigid than benign tumors as a rule. In dermatology we have some exceptions, as we have so many benign tumors with collagen, then this would be the exceptions. We have to take into account that collagen tends to be rigid, then any tumor that is rich in collagen is also going to be hard, despite it's benign or it's malignant. Okay? Then, as you see, you have to know about the biology of the skin.